My name's Kate Niemans. I'm with the Mental Health Legal Advisors Committee, and I was going to do some brief introductions of our panelists, but I'm going to let them do that themselves so that you can hear more of them and a lot less of me. Two quick announcements. Anyone who's a CPCS attorney should make sure before they leave to sign out for the day. That's very important for your credits. There's also been a bracelet that someone's dropped, which I have. I'll be sitting in the front row. So if you've lost a bracelet today, just let me know and you can claim it. This is the panel on racial and ethnic disparities in mental health treatment and teaching, learning and teaching cultural humility. And I think we're going to dovetail really nicely into this panel from the discussions that we've been having about mental health and mental health systems and mental health treatment. So I'm going to let our panelists take it away.
Good afternoon. All right, so I want to tell you two things about this slide. One is it's missing my middle name, which is Lê, which has a circumflex over it because my mother's family is Vietnamese. Lê is my mother's family name. She's a social worker who's been here since the 60s, trying to resettle refugees from Southeast Asia in Northern Virginia and train police officers in how to do a better job with individuals with mental health problems and racial and ethnic minorities. So that's my family business. And that's what I've been working on with her since I was a kid writing grants in 7th and 8th grade. And so now I wanted to share that with you. She's a big part of my life and a big part of why I'm here. The second one is the Health Equity Research Lab. Cambridge Health Alliance is a safety net institution right down the street from here. We have 3 hospitals, 15 community health centers, a mission to deliver equitable care. We do research there that evaluates disparities, reducing interventions, and tracks what's happening with the country in terms of mental health care disparities and substance use treatment disparities. Okay, so that's my first slide. All right, I'm going to start by painting a picture of what's happening with the country in terms of mental health treatment, get fairly quickly into the patient-provider interaction and discrimination in the patient-provider interaction so I can set up my close colleague, Valeria, who's coming on next, who's going to be talking about our joint community and research work. And we'll go into a lot more detail in those areas. So what do we know about prevalence of mental illness in the United States? This is getting old now, but there are a lot of studies that look similar, that African Americans and Latinos have rates of mental health problems and rates of anxiety disorder and mood disorder that look the same or even lower than whites. Okay? So this is a community sample. This isn't just who makes it into care. This is finding everybody in their homes through telephone or through in-person and seeing what their rates of mental health disorder are. So in a way, you could say this is not a disparity. You want to think about it that way. The disparity arises when you think about among those with mental health problems, what is the persistence of those mental health problems, and what is the severity of those mental health problems. David Williams, who you heard from earlier today, has a study that shows that among those with depression, blacks are more likely to have severe depression than whites. This study by Breslow and others shows that among those with lifetime mental illness, blacks and Latinos are more likely to have last year mental illness. What does that mean? That means that their mental illness is more likely to persist over long periods of time. Okay? So this is where the disparity in mental health is in our country. The rates of anxiety, of depression are actually quite similar across racial and ethnic groups. What's different is the persistence of that mental health and the severity of those mental health problems. So there are a lot of ways, which I don't have time to describe what's underneath there, and we're trying to understand what's underneath there. Let me tell you about a couple things really quickly. The intersection of neighborhood segregation matters a lot, and we've been trying to uncover what's going on in neighborhoods and how that relates to those disparities in persistence and disparities in severity. Where you live matters a lot for employment opportunities, schooling, the kinds of high-risk jobs that individuals have, housing quality, access to healthier foods, crime and homicide. And then there's treatment, and I'm going to talk about that. There are big disparities in this country in access and quality of mental health care, and then discrimination inside and outside of the healthcare system, and I'll touch on those things. Okay, so imagine this is the population in the United States with psychological distress or with depressive symptoms. So this is a fairly disabled group. So this is about 10% of the population in the United States has a K6 greater than 12 or PHQ-2 greater than 2 that represents psychological distress or depressive symptoms. Among that group, this is a group that is having trouble with depressive symptoms and distress, and 40% of whites initiate any care in the last year. So that's a striking number, right? Imagine that in diabetes, where you have diabetes without any treatment in the last year. That number is like 80% for cardiovascular disease and for diabetes care. It's 40% for whites in mental health care. And it's 24% in blacks and 27% for Latinos. So 1 in 4 of African Americans with psychological distress or high depressive symptoms initiates any care at all in the last year, in that year in which they were surveyed. Adequacy of care, we define adequacy of care as something that was very minimal. Getting 4 visits and a medication in a year, or getting 8 visits to a psychologist or a primary care doctor for your mental illness in a year. This is a low bar. Look at those rates, 16%, 10%, and 11%. This country is not doing a very good job at getting people who have mental health problems into care, and then once they're in care, most people leave after 1 visit, maybe 2 visits. They don't make it to 4 with the medication, and they don't make it to 8 with the medication. And there are huge disparities, 2 to 1. Here it's 40 to 24 and 16 to 10. In other studies, you see 50 to 25. You see almost 2 to 1 disparities. Again, you don't see that in any other part of the medical care system in the United States, but you see it in mental health care. Over time, it looks worse. This is a disparity on the y-axis here, and the general trend is that these disparities are getting worse over time. So that green line is Asian white disparities are large and they're getting worse. The red and the blue lines are black white and Hispanic white disparities, and they're getting worse in terms of accessing mental health care. Okay, so now there's some recognition that mental health care in the country is a problem. The Affordable Care Act comes in and has a lot of potential for helping people who have had cost barriers to get mental health care. So we've done a study that looks at how the Affordable Care Act has improved mental health care. And it has overall. So you can see increases. Remember I was saying it's about 40% among those with serious psychological distress? That bumps up here for the entire community. But there's no reduction in disparities. The Affordable Care Act ensured enough folks to increase access to mental health care, but it didn't change disparities at all between Hispanics, blacks, and Asians. All right, that's the lay of the land, what's happening in the country. It's stark. If you're looking at substance use treatment, it's much worse. Only about 5%, between 5 and 10% of individuals diagnosed with a substance use disorder receive treatment, 5 to 10%. Most of those people have hit rock bottom before they get substance use treatment. They get it through the criminal justice system because it's mandated. They get it through their employers because it's mandated. Very few people in this country that struggle with addiction are receiving any services at all. I want to switch to discrimination. I know this has come up in earlier slides, in earlier presentations. 42% of blacks say they've experienced violence or threats because they're black. 51% of blacks say they've personally experienced people using racial slurs or negative comments. Related to health care, 22% have avoided seeking medical care out of fear of racial discrimination. So these are nationally representative surveys that show that. A lot of people are avoiding seeking medical care because of discrimination. We haven't gotten to mental health care. Medical care, a lot of folks are avoiding seeking medical care because of discrimination. So let's think about what those personal experiences of discrimination lead to. Increases in psychological distress. There are a number of studies that make that link. Depression symptoms go up. Studies make that link. Blood pressure goes up. Increase in cortisol, other stress hormones are associated with those experiences of discrimination. There's a nice summary that has a lot of those that show the outcomes of perceived discrimination and its impacts on health. The anticipation of prejudice, not even the experience of it, but the concern that you're about to experience prejudice, or you're about to walk into a doctor's office and you're anticipating that you're going to experience discrimination again. That also has impacts on your physiology, on your distress, on your cortisol levels. If you start to now move and start to think about the criminal justice system and stop and frisk, and a lot of policies that have been in law enforcement for a long time, that anticipation now may lead to hypervigilance. Your anticipation of having a bad experience when you're walking home, when you're coming back from school, when you're going into the doctor's office, creates hypervigilance, which has been shown to increase physiological arousal, cortisol, blood pressure, heart rate, etc. We did a study, a national study, that showed that it's a little more than a third of African Americans think they were treated unfairly because of their race color by their medical provider. There's also between 5 and 10% of individuals that thought they were being treated unfairly because of their language accent, especially high among Latinos, as you would expect, and then sexuality and gender as well. Looking at frontline staff, we've had a lot of discussions with individuals who experience the mental health care system that find that frontline staff is where they find a lot of discrimination. Here we found above a quarter of African Americans were treated unfairly because of their race and color by frontline staff. So just walking in the door, making the appointment, you're experiencing discrimination for a large subsection of the population. So if we keep digging at discrimination in the healthcare setting, Chapman has a nice review that shows that pro-white, male, young, non-Hispanic, non-obese biases are widespread among physicians and medical students. A lot of studies with medical students that show that they come in with that, they're not getting a lot of training to train those biases away. There's increased provider implicit bias associated with this idea of physician verbal dominance. If you're being dominated verbally in a visit, you're not going to come back to that visit. Gets back to those adequacy of care statistics I showed you. And there's worse medication adherence among Black patients associated with that implicit bias. You've heard some of the recent studies about pain medication. We are really focused on the opioid epidemic. There's also an under-prescription epidemic among African Americans who have pain, an under-prescription epidemic for sickle cell for African American children whose cells are sickling because they are not having enough pain medication. That's the flip side of that, the pain overdose epidemic that we're not seeing right now. Now, digging again, so discrimination, what does it mean for patients with mental health problems? Black people with mental health conditions, particularly schizophrenia, bipolar, and other psychoses, are more likely to be incarcerated. Black individuals are disproportionately more likely than whites and Latinos to be forced into psychiatric treatment and medication. So we're talking about sectioning here, the idea of being sectioned, involuntarily committed to psychiatric treatment, chemical restraint, and those ideas, much more likely among African Americans. I've talked to police officers about this who say, I can't section somebody, I take them to the ER. African Americans are much more likely, once they're in the ER, to be sectioned by doctors or family members there and put into involuntary psychiatric care there. Okay, so now we're trying to get more of the voice of patients who have been through this. And I want to raise this point about having to worry about the provider's comfort. This was news to me, working with Valeria and the Transformation Center and Blacks United for Recovery. You'll hear more about them coming up. I'm African American. This therapist I'm talking about is white. I've had some things happen to me that were racially, when I was a kid, racial violence. And so if the therapist is white and they're going to be uncomfortable about me talking about something, then that's not a good fit. We've heard this a number of times that the African American patient spends 30 minutes of their 45 minutes trying to make their provider understand their context and then trying to make them feel comfortable. You almost have to ask the question, like, who is making who feel comfortable? 30 minutes of the 45 minutes, and then I get 15 minutes to work on my problems. I spend 30 minutes trying to make them feel more comfortable. Well, that's important because the provider keeps them from being sectioned. Making the provider comfortable with them as a patient ends up being hugely important because they're the ones that can keep them from being sectioned. So this quote says, no one is going to listen because I'm mentally ill, but if my doctor says she is fine, she can do this, they will all back away. So that interaction between the patient and the provider is fraught in this context of involuntary psychiatric commitment. So, to summarize, there's similar lower prevalence for racial and ethnic minorities and mental health problems, greater persistence and severity, and there are a number of reasons underlying that. We see 2-to-1 disparities in mental health care access, and that's a bigger disparity than any other part of medical care in the US. There's a real need to work on fear and mistrust, working with criminal justice who are on the front line of working with people with substance use problems and mental health problems. There's a lot of work to be done with provider discrimination and then making treatment relevant to minority communities. And there's going to be a lot more talk about that coming up. Thank you.
Good afternoon, everyone. I'm Valeria Chambers. I am the Community Voice Policy and Research Coordinator for the Transformation Center. I'd like to do 3 things with my time with you today. 1, share about the Transformation Center's work, our connection with Ben's team in research, and lastly, I'll focus on our work in the Black communities that points to ways that you can support us as allies. Because it is truly wonderful to see your commitment in your presence, in your questions, your concerns. The Transformation Center grew out of the civil rights movement. We are people with lived experience of mental health conditions, diagnosis, and extreme emotional states. When we disclose a mental health condition, there is a high cost. We can lose relationships, jobs, even our children if we disclose to the wrong person. However, at the Transformation Center, we do disclose. And we use our experiences to bring about a world that supports recovery and healing. We have a vision for trauma-informed communities, and our Central Mass Recovery Learning Community is highlighted by the Substance Abuse and Mental Health Administration for this work. Blacks United in Recovery. In our statewide work, we have a lot to say about trauma and racism. One person put it this way: people fear us and justify murdering us because they are afraid. They still don't realize that they are the originators of this horrible story. Another person said, "It is not right for someone to have to endure trauma for the cause of liberation, and then have someone else say, 'But we really need you in there doing this work.' So in other words, just suck it up and keep getting victimized." So the role of allies is crucial. It is why we work with Ben and his team, and why I'm here today to connect with all of you. The Transformation Center works hard to bring about trauma-informed mental health services. We have found that these systems don't change easily. We have taken to heart the motto, nothing about us without us, from research to policy and to practice. One strategy we use is our Certified Peer Specialist program. We train and certify people with lived experience to provide peer support within healthcare settings. These CPS are bringing about change every day. Thanks. You can see here that when a CPS works within a treatment setting, people are far more likely to stay with the service because they are heard and supported by someone who is also working hard on their ongoing recovery process. Certified peer specialists help mental health staff reverse subtle or not so subtle messages about the status or value of the person who needs help. One of our Blacks United in Recovery participants put the need for healing into words. Reconnection is needed between ourselves, within ourselves, and in our communities. This participant describes both the personal and the collective components of reconnection. Another person said, "We have to take into account collectivism versus individualism, because the medical model is so individually focused. Otherwise, it is not understood that the individual view by itself is not sufficient. We know that identity matters in all mental health treatment, but it matters even more for people of color. Identification with race, culture, or their non-English language provides an important protective measure and can be a much-needed source of personal and communal self-esteem that can hold deep meaning. If this is not explored, welcomed, and understood by people who seek to help us, so much can be erased or violated within systems that are built upon powering over and lack of cultural responsiveness." At the Transformation Center, we're working with affinity groups to bring forward the identity-specific voices of many groups: deaf, young adults, LGBTQ+, Latinx, Asian communities, and Blacks. But at the same time, we realize we must also learn how to receive these groups in ways that will truly welcome them and allow them to be who they are, contributing their gifts to our community. One BUR member, Blacks United in Recovery, pointed out how empty the term cultural competence is for most of us. She said, "It's cultural humility and cultural responsibility, not cultural competence. Because cultural competence implies, well, I read a book, I took a class, and now I know how to do you." We notice that disparities are not going away and that new solutions are needed. So dismantling racism on all levels and creating true access is about system-wide investment. We are talking about new investment driven by the vision of these powerful voices. Ben invited the Transformation Center to work with his team on the PCORI grant he just spoke about. Oh, missing a slide. We were honored to be asked to work with him. But I have to admit that working closely on a project about how current clinical services are offered was a huge stretch for us. because based on what we were hearing from our communities, we were working hard to develop alternatives and new approaches, which people said they wanted and needed. We were quite surprised to see that the experiences that BUR participants have been reporting were reflected in the data. Looking closely, together with Ben and his team, has provided us with validation. It has enabled us to talk in a common language and build trust within our research group meetings. After a few years of working together, Ben urged us to apply for our own grant, and we partnered with him and his team. We called it Blacks Addressing Mental Health and Healing Through Comparative Effectiveness Research. It was a one-year project that gave us the opportunity to reach out deeply into the community and learn about what questions Black communities have about what works and what doesn't work in mental health care. In the project, we established a trusting relationship between researchers and community advisors, and it was no easy thing. It took months to do. We had iceberg breakers to help us get the conversation, personal sharing. If I had a couple of hours, I would tell you about it. But what I think is most important for the moment is for you to hear what Blacks were saying in those meetings. First, let me tell you a bit of my story. I am Black, and I have lived experience of mental health recovery. But I have a lot of privilege that has protected me in dealings with the mental health system. Both my parents were mental health professionals, and I myself became trained as a psychologist and pastoral counselor. I had an understanding of culture. I could read between the lines. If there was a hint of bias, I knew how to handle it. Most of us are not able to do that. Our work showed so clearly that Blacks often avoid treatment, therapy, or office visits simply to not have to be confronted by racism. One person said, having to shut down your feelings in the mental health system in order to get your health care, going to the hospital, being admitted, but not getting your needs met, not being listened to. Often these experiences were extremely traumatic, sending a person straight into fight, flight, or freeze, where cognition shuts down and instincts takes over. At our summer forum, we had people fill out a survey to get a sense of whether they could relate to the findings that we were discovering in our discussions every month. And what we found was Blacks and the allies present had very different concerns. There was lots of overlap too, but we came to realize that there are differences in perspectives. One person said, healing is healing no matter how it is done. Community healing, healing from poverty, intergenerational healing, liberation from all oppression and racism. Another person said, to be aware can lead to anger, but moving through the anger toward empowerment is healing. In conclusion, our affinity group has a vision of wholeness, connection, balance, and healing. Communities know what is helping, what is hurting. They want desperately and need opportunities for healing now, not years and years after policy, research, and planning. Our communities have a vision, a healing vision that is gradually emergent. It is practiced in some places right here in our midst. They are coming out of the grassroots movement. Places like the Corey Johnson Program for Post-Traumatic Healing, a free trauma program that happens every week. They have had such success that there are so many people coming. The Transformation Center is looking to help clarify and advance this vision in as many places and as many ways as possible throughout the Commonwealth. Current systems keep identifying healthcare and mental health care disparities, but we are looking at how systems can invest in new solutions, because the old ones are reinforcing disparity. In this regard, we are building understanding among allies and stakeholders that Black communities have some solutions to invest in that are already proving to be effective. Thank you very much for your presence. It is a pleasure to be here.
Hello, everyone. I'm really excited to be here. My name is Oyenike Balogun-Mwangi. I am trained as a counseling psychologist, and I'm currently an assistant professor at Salve, Regina University. I am Nigerian, and let me not be the first one. Thank you. Let me not be the first one to tell you the number of letters in your name directly correlate with how you're loved, how much you're loved. So I've got a lot of letters. But I hope that a little study that we've been doing for the last 2 years that I did as a postdoc will inform a lot of what we've been talking about today. I'm certainly excited to sort of add something to the conversation. So really, you know, the way I sort of think about the next 10, 15 minutes I have is to say a little bit about what we know, and a lot of it mirrors a lot of what Ben and Valeria have talked about. Talk about the limitations of what we know about how race and mental illness are related and how we can understand that. And I'll say really quickly and touch really quickly on our study on multiple stigmas, which was focused on Black adults with serious mental illness. And I'll say a little bit at the end about why I think the focus is really important, and speak specifically about an intersectional lens. So I hope that will be helpful and add to the conversation. But I wanted us to start by considering this. I teach a cross-cultural psychology class currently, and currently we are in a chapter about psychological disorders, and it is a current edition of the book. It's a 2017 edition. But in that chapter is a study that was cited from 1995 that basically made the argument or stated that Blacks had higher rates of agoraphobia than whites, and tended to show higher rates of phobia that did not remit with treatment. So my question to my class of 19 undergrads, 3 of them of color, was, okay, this article is making an argument that race is a factor, right? So let's talk about that. Let's throw things at the wall and try and understand what is it about population of Black adults in America that might explain what this article is saying that they found. And I was excited to see the students sort of engage in the conversation, and I would tell you, a lot came out of it, but briefly, sort of the conclusion was this incredulity at the end where students were like, well, isn't it a normative response? Like, wouldn't you expect that Blacks in America would respond in this way. And I know a lot of people in the room are not clinicians, but when we're talking about agoraphobia, we're talking about, fear, intense fear in specific situations, usually one or more. Public transportation, standing in line, being in big crowds, being in large white spaces, closed spaces. And typically there's a strong avoidance of these situations. So people who are dealing with agoraphobia usually end up being reclusive and staying in the one place that they find safe, and only venturing out if they have significant amounts of support, right? So students at the end were like, well, it seems to me like that's a normative response. If I were Black in America and had, a higher chance of being arrested or shot or, experiencing racism out in the great outdoors, wouldn't I have higher rates of agoraphobia? And one student was like, is it a fair diagnosis to give, to give these individuals if there is sort of a socio-cultural explanation for what could be happening? Now, there were more questions at the end of the class than there were answers, but that's usually my indication that that was a really great class, right? But there were a lot of questions, but I think for me, in that moment, it was very clear to me that I did not have those types of conversations in my clinical interventions class as a counselor in training, and I think Dr. Cort is going to talk about that in a second, that I wasn't having these conversations. And I'll come back to this in a second because I think it's an important consideration, and I say this for a reason. So in terms of what we know about the literature, you will see, Ben really focused on this earlier in talking about kind of what we know about mental health disparities currently. And I sort of think about the different types of themes in the current research are sort of falling into 4 categories, and you probably have seen that in a lot of what Ben and Valeria talked about, which is a real focus on need, right? So at the individual level, Black adults with serious mental illness have high rates of attrition, high rates of mistrust of the system, high rates of underutilization of care. Why is that? Let's try and understand that. At the community level, high rates of stigma in the Black community around mental illness. Why is that? How can we unpack that? And the third category is treatment. And I believe Ben and Valeria touched on this idea of trying to reduce provider bias and diagnostic bias and trying to increase cultural competence. And the conversation is moving towards cultural humility, and I believe Dr. Cort will talk about that too. And then we get to the systemic level. And what you will see is typically an allusion to that, right? Racism plays a role, structural inequality plays a role, right? But we talk about it as a role. So now, and Ben has talked about this, there is strong evidence that racism is associated with poor outcomes. Physical health and mental health. There's a preponderance of evidence, right, that this is the case. Now, you won't hear a lot of statements about causality, although I heard you talk a little bit about causality, like, we can relate racism to higher hypervigilance, for example. But we're not at a place where we can make those types of leaps yet, like talk about causality or say that racism exacerbates conditions by a certain degree, right? And I, at this point, I think that I have a real impatience with that right now, because I think we need to get to the place where we're sort of unpacking and understanding what it is that race contributes to the presentation of mental illness, to the course of mental illness, the manifestation of mental illness among Black adults. And that certainly was our focus as we were thinking about our study. So our study was really focused on stigma, and it was focused on stigma among Black adults with serious mental illness. And one of the gaps that we were trying to address in the stigma research is this idea that if, stigma research is very, very deep, miles and miles deep, and mental health stigma research is also deep. But what you will find in the literature is that there's usually a focus on one stigma and how it impacts people's lives. So there's mental health stigma, how does it impact work outcomes? There's mental health stigma, how does that impact social-emotional outcomes? But it's usually looking at one slice, right? So if we're thinking about Black adults with serious mental illness, and we're talking about racism established as being a factor, then when we're talking about these individuals, at the very least, we're talking about 2 stigmas that operate maybe simultaneously, right? And that we felt was sort of missing in the research. It's talking about how individuals can have compounding stigmas that are operating at the same time, and what does that mean for their lives. I'm gonna come back to the slide at the end for a second, but I'm gonna do the overview of our study. So over 2 years at Boston University, we ran a qualitative study focused on looking at the experiences of work adults in one context and looking at multiple stigmas in one context, which was work. So we interviewed 30 Black adults, in-depth, semi-structured interviews, and then ended those interviews with a follow-up focus group. And in those interviews, we're trying to find out, what is your experience as work, as someone who identifies as Black and also identifies as having a serious mental illness? Are you experiencing prejudice or discrimination at work? And what are the reasons why you think that these are happening? So we spent many months sort of thinking about the responses that we got and transcribing them and coding them. And we're going to talk about the results of just the workplace right now, because I think it does inform the conversation that we're having today. So really quickly, we ended up with 24 individuals. We couldn't include 6 because they didn't speak specifically about stigma in the workplace, so they're included in a second study that we're looking at right now. So individuals were 24 to 63 years old, 11 of them were female identified, 13 were male. Most of them identified as single, never married, and 17 were unemployed at the time of the interview, but had to have been employed within 5 years of the interview to talk about, we thought, to sort of provide substantive information about what they were experiencing at work. So I know this is a heavy slide, but I'm gonna unpack it, I promise. So in talking to these 24 individuals, they identified to us 19 different stigmas that they experienced in the workplace. The top 3 being race, mental illness, and gender. So if you'll notice, race was endorsed by all the male-identified Black adults with serious mental illness in our sample, all of them, and half the women. Mental illness was identified by about half of the male-identified, half of the female-identified, and gender was identified by about a third. And I can certainly talk about the specifics of each of those. But I did want to point out the sheer number. We're talking about 24 individuals identifying 19 stigmas that were operating in their workplace. Appearance was one of them, criminal history, substance abuse history if it was known, weight, not having the standard accent. So things like that came up. So that's exciting and certainly important to think about when you want to consider what a day-to-day experience is for Black adults with serious mental illness for us to think about. But I think for us, it was really looking at how these experiences were clustered together, and that was the multiple stigmas bit that we wanted to understand. So this idea that individuals, if we ask them a question, for example, they would, one example was an individual who told us that his supervisor would always have a knife nearby. He worked in a restaurant because he was afraid of him. And my question to him was, why did you think that that happened? And they felt that they needed to protect themselves from you. And he said, well, I'm a big Black man with a criminal history. I'm a triple threat. So in that response, he identified physical size, his gender, his criminal history as operating at the same time. So in that case, we're seeing 3 stigmas being clustered. And not only that he was aware that those 3 stigmas were operating at the same time in his experience at work. So I do want to point out really quickly that what you will notice is that race was part of 10 of the 13 clusters that we identified. So for individuals who were able to say, multiple stigmas at work here, and the way I'm being treated at work, race made up 10 of the 13, mental illness made up 7. But these sort of compounding experiences is not just us identifying it, it's individuals saying, well, all these things were in operation when I was being treated in this way. So I'm gonna go back to that slide from before and say that part of the question and part of the reason why we're doing this was in really looking at the intersectional research, which is, I think, where things are moving right now. This idea that we need to start looking at how multiple disadvantages are really impacting people at the same time and trying to figure out how these multiple disadvantages are really working and operating. I think that's where we should be headed, right? It's really thinking about, so is this an additive thing? Like if you're adding, is it a 1 + 1 + 1 thing, right? What is the effect of each additional stigma that this individual is experiencing in the workplace? And what does that mean, right? When we're looking at the clinical picture. So in my mind, when I was in class thinking about the conversation I was having with my students, is that race, at this point, pulling together all that we know, race is often talked about like it's part of the clinical picture. But race is the clinical picture and really needs to be seen as a sort of a central part of how we understand how mental illness is manifesting. So I end with this, that what our little study, at least, is sort of contributing to this conversation, right, is this idea that when we're looking at the experiences of individuals, looking at the experiences of Black individuals with serious mental illness, are we at the point where we can start to really design studies and think about the research as showing how race actually can explain the symptoms, right? How maybe it can explain the course, the exacerbation of symptoms, how they manifest, the acuity, right? Because what Ben talked about earlier in the first slide is that we can see that there are differences in severity. Maybe there isn't differences in prevalence, but certainly when we look at the symptoms, it may be that that individuals in marginalized communities are really experiencing more serious manifestations of the illness, and it tends to have an irretractable course. You know, they suffer for longer and they certainly have more serious symptoms. So can we start thinking about how maybe we can start unpacking the role of race in a sort of more intricate way and really understand the impact, so we can start to really think about how this can inform treatment and how we can inform maybe our diagnostic decisions. Should we be qualifying some of the things that we say when we're handing out a diagnosis? When we think about the context in which mental illness is presenting in that very moment. So thank you so much for your attention. I hope we have a chance to talk about this later.
Good afternoon, everybody. I am recovering from a bit of a cold, so I hope that you can hear me. I am Dr. Natalie Cort. I am a clinical psychologist and an assistant professor of clinical psychology at William James College, which is in Newton. I am also a core faculty member in our Center for Multicultural and Global Mental Health, and the director of our Black Mental Health Graduate Academy, which relates to what I'm going to be speaking on today. The Black Mental Health Graduate Academy is an academic pipeline program to recruit and mentor and support dynamic, talented, future Black leaders in the field of psychology and mental health. And that's part of our effort to address some of the disparities that have been noted by my colleagues. So as a professor, as a Black woman, I am frequently aware as I stand in front of my students who are predominantly white that, thank you, that my very presence is challenging. I am aware of the fact that they're oftentimes experiencing a level of cognitive dissonance as I stand there before them teaching adult psychopathology. And I say that not because it's my perception, I say that because my students have actually shared that with me, that sometimes it's really challenging for them to actually pay attention to what I have to say about major depression, because They're confused that there's a Black woman standing in front of them with a Ph.D. who is the authority on mental illness in the room. Because for them, growing up in this country, excellence hasn't been attributed consistently to people of color. And my students are, on a frequent basis, really struggling with that as I try to teach them adult psychopathology. So I want to just really emphasize how significant the issue is in terms of us even trying to address disparities, because frankly, I can't really be effective in helping them figure out how to diagnose mental health problems, and particularly diagnose mental health problems as it occurs in communities of color, if they're challenged by my very presence, right? If they're struggling to figure out, what are you doing up there, right? So I have to dismantle barriers before I even get to talking about anxiety disorders, right? So that is the depth of what we're dealing with. We're in a field that is an ethnocentric one. We're in a field that is a monoculturalistic one, meaning that this is a field, the field of psychology and mental health, has been largely shaped, whether it's our theories, our interventions, our research trials, largely shaped typically by European white men, right? Lovely, lovely men, no doubt, but obviously a very, very small percentage of the actual world population, right? So therefore, the theories that they've come up with about psychopathology, about how behaviors and emotions and thoughts get impacted by psychopathology, really could only reflect a very minority of what psychopathology likely looks like. And so for me, in teaching this work, it's really about cultural humility, which Valeria highlighted. It's about recognizing the fact that the matter is we're just at the beginning of understanding mental health issues, and we have a lot of ways to go. Unfortunately, as we are on that journey, there's a lot of tragedy happening in our field, and a lot of tragedy that is impacting the lives of people of color primarily because of some of the historical issues that this country has had that remains unresolved in relation to race and ethnicity, oppression, marginalization, discrimination, et cetera. So as Ben shared in terms of his research, we see how those disparities are showing up in treatment. I primarily am focused in my work on helping my students be decent diagnosticians, because really it oftentimes begins at that level, right? I talk to them about the misdiagnosis to prison pipeline that's oftentimes very present in the lives of youth of color. I highlight to them that President Bush had a commission in 2002 that found that we, mental health providers, well-meaning, caring, educated people, were right at the beginning of that misdiagnosis to prison pipeline, that we were actively participating in pushing young boys of color into that pipeline that we all hear a lot about. And I remember when I read the words that misunderstanding and misinterpreting the behaviors of racial ethnic minorities have led to tragic consequences, including inappropriately placing minorities in the criminal and juvenile justice system. When I read those words from President Bush's commission, I was astonished. I was taken aback that we as providers were being identified in such a way, that we were being that they were stating that we were contributing to this tragedy. But the fact of the matter is we are, and that goes back to the fact that we are working with a very narrow perspective of mental health, a narrow perspective of ways in which to treat mental health. And so, of course, that shows up in our diagnostic practices. So There are many, many ways, and Ben has highlighted many ways in which disparities in the field show up. They're innumerable, and they create incredible burden on people who are already struggling, already confused, already in despair, already in need of help. And I like to share with my students just an example of that misdiagnosis to prison pipeline. So what are we doing at the beginning of that pipeline? Well, we are misdiagnosing youth of color, and we're doing it at epidemic levels. We are seeing kids who are presenting with some of the most severe symptoms of ADHD, children who are presenting with risk factors for ADHD, and then we're not diagnosing them correctly with ADHD. We're diagnosing them with something. It's just not ADHD. We're identifying them as oppositional and defiant. We're identifying them as mental health providers as badass kids who just don't want to listen, they just don't want to sit still, they're just being deliberately defiant. And so you can imagine if that's what's happening in our school systems, which is what a study with 17,000 youth across the country showed, that Black children with ADHD were almost 70% less likely to be accurately diagnosed with it. For Asian and Latino kids, that they were 50% less likely to be diagnosed with ADHD. But again, they were diagnosed with conditions that actually grow up into conduct disorder, which then grows up into antisocial personality disorder, which happens to be the condition that is most prevalent where? In our criminal justice system, right? So for those children identified as oppositional and defiant instead of having ADHD, obviously they're not going to be receiving the necessary treatment, the correct treatment. We also find that even when they are identified accurately, they're less likely to be provided with the treatment that they need. And we know a lot about ADHD when it's untreated, when it's unidentified, when it's untreated. It just so happens that one of the consequences that the research robustly demonstrates is incarceration. So this is just one condition, right, that gives you a glimpse of that misdiagnosis to prison pipeline, how it proceeds, because that child with ODD that becomes conduct disorder, that's the child who's getting expelled from school, who's getting suspended, and the Department of Education highlights the fact that suspension is predictive of involvement in the criminal and juvenile justice system. So this is not rocket science, people. This is really simple math here. But it's really important for us to be able to take that information in without being too defensive about it so that we can actually make change. So we also see, in terms of schizophrenia, just incredible, incredible disparities. It pains me every time when I see these, the research on schizophrenia. Schizophrenia is a highly, highly genetic condition, incredibly genetic. And guess what? There's no genetic differences between the racial categories that exist in this country. And if you guys don't know this to be true, since 1790, every census that the United States has had different racial categories. There's no 2 years where the racial categories have ever been the same, because we made it up, right? So if there's no racial differences, that means that when we see significant differences in people who are represented in inpatient units with psychosis and psychotic conditions like schizophrenia, when we see Blacks being diagnosed 4 to 5 times more with schizophrenia, we know that that is incredibly wrong, that we know that that is tragic, and we know that that's incredibly problematic and must stop. So these are some of the issues that we're seeing diagnostically, and as Ben highlighted, these issues are showing up in terms of treatment. So why is this happening? Well, there are lots of reasons. And my colleagues highlighted some of the sources of disparities in this country. But for me, standing in front of my students, my job is to highlight to them that they're at the beginning of the pipeline, that their implicit racial ethnic biases play a significant role in the decisions that they make diagnostically. So what must they do in order to reduce these disparities? Well, first and most importantly, we need to be culturally humble. We need to realize that competence, as Valeria highlighted, is not something that you're going to achieve, because culture reflects humanity, so it's dynamic, it changes, it's complicated, it's messy, it's incongruent, so you're never ever going to get an A in cultural competence. What you can do is recognize that this is a changing, lifelong process that requires your curiosity, your openness. It requires that you put away your pomposity and arrogance to know that you don't know everything. I don't know everything about the person sitting in front of me. The person who's sitting in front of me who has multiple cultural identities within that one body, right? Because they're a psychologist, and that has a culture that comes with it. Because they're in an Italian family, and that has a culture that comes with it. Because they're Catholic, and that has a culture that comes with it. So culture is dynamic, and so it's really important for us to be able to move through this process, this diagnostic process, with a respectful attitude towards others who come from different cultures. So for me, it's really simple. Cultural diversity is not something that I think we must tolerate. I think it's something we must party and celebrate, because it's amazing and it's awesome. I prefer a heterogeneous world than a homogeneous one. Boring. So that's what I'd really like to highlight. One of the things I encourage my students to do is to ask themselves, have you examined your implicit racial biases lately? Actually, I share with them that I typically, when I'm speaking to audiences of color, I share with them that they must ask their clinicians this question before they sit down. And if they get a blank look, if they get, huh? If they get, what's that? Then I need them to get their bag, turn around, and leave. Because I can guarantee you, President Bush's commission highlighted the fact of the matter is, if your clinician does not know the word implicit racial or bias, you are going to be misdiagnosed, and you are going to have to live with the burden of that misdiagnosis. So at the very least, have you examined your implicit racial bias lately? Thank you so much.
All right, I want to thank our panelists, first of all, and for our audience members for sticking around. I'm glad to see a number of people are still here. I'm going to start off with a planned question, and then we're going to open it up to questions from the audience, because I know that we've had a lot earlier, and I want to make sure we have time for that. So a couple of the things that I want to pull together on this, there was a recent Mass Lawyers Weekly article in which quoted Chief Justice Paul Akarian saying that the Probate and Family Court has seen a dramatic increase in the number of filings of Section 35 petitions, which are petitions to civilly commit and involuntarily treat an individual with an alcohol or substance use disorder where there's a likelihood of serious harm as a result of that disorder, and these commitments can last up to 90 days. These filings have exceeded 10,000 per year for the last 3 years, and just to put that in perspective, in 2011 there were only about 5,800 filings. So that's a dramatic increase. So we know that many of these individuals who are getting civilly committed are dealing with co-occurring substance use and mental health disorders. And this is just one of the ways in which this population is being subjected to involuntary treatment. And we've had a couple of our panelists mention involuntary treatment and when that's occurring for these folks and how that's leading to their accessing mental health treatment, although not voluntarily. So our legal system has a number of different places where coercive or compulsory treatment is required, whether it's in the context of probation or parole in the criminal justice system, whether it's requirements for treatment in order to access one's children in the child welfare or family court arenas, or even requirements for children to be engaged in treatment when they're the subjects of children and requiring assistance petitions in the juvenile court. We also know that people of color are typically interacting and subjected to the legal system, and particularly criminal justice and child welfare systems, more often than others. And so what I'm wondering is if the panel can comment on how effective compulsory or coerced treatment is for these individuals, and what do we need to be particularly cognizant of in relation to people of color in those circumstances when they're being coerced or required to engage in this mandatory treatment. Anybody who wants to take a stab at that?
Yeah, I think it's so interesting to me. Coercive treatment, would that be effective? Well, I think we know a lot about self-determination and human behavior. And part of what we know is that there needs to be a level of autonomy in terms of behavior change for it to actually be sustained. So the very nature of that level of coercion and involuntariness to the process is in direct opposition to what research highlights about how people change in terms of their behavior. So, and I'm not in any way attempting to be Pollyannish about these struggles if somebody is actively psychotic and in a state of acute psychosis and dysregulated, that these are issues that we have to respond to in a realistic way. But I think that it's really important for us to keep having the conversations about the ways in which we continue as a field to re-traumatize a historically traumatized group of people.
I would just add that it's such a good indicator of how dysfunctional our system is that we've now come to a place where we're considering that as a policy for healthcare in the United States. There should be a lot more attention to getting treatment to folks at earlier stages. Resources should be put into getting access to outpatient treatment, to referrals early. Community health centers should have longer hours. There are so many things that could be done at earlier stages that we should be focusing on. It's almost like the number of sections that we see is a great indicator of how bad the system is. So if we see those going up, that's a great indicator of how badly the system is performing. I think there's a lot of ways to do this in community mental health centers and hospitals, and there's been a lot of focus on integrated care. I think that has a lot of potential in the healthcare system, but there's also a lot of focus in integrated care on saving money, and I don't know if the physical health and mental health integration is working for people. In fact, I think it's making the issues of earlier treatment and identification worse. But it does seem like a real negative indicator.
And I think, what I would add to that is I sort of go back to what you initially talked about, Ben, earlier, which is your example about research about sort of physicians in the room with their clients and this verbal domination that you talked about. And I think about this issue as a clinician, right? Is thinking about someone being in the room with me and often having these conversations. I think it's an ongoing conversation because, yes, we understand that mandated treatment and being and having structures in place that are meant to sort of reduce harm is necessary. But I think in the one-to-one, I think about the difference between getting someone to adhere to what I'm talking about and me sort of preaching to them about what I should do, and the difference between that and treatment concordance, which is them really having some agency in their own treatment and being part of what they think is going to help. And that certainly has to be, I think in my mind, front and foremost, is that I'm not the one sort of dictating what happens. And I think the very core of what mandated treatment is that everybody else is dictating. Very rarely is there a voice in the room. And as a clinician, even when I'm in situations where someone is mandated to see me, that even in that small space, that I'm creating some sort of control and agency for them about what happens in the room. And if they come in and they're mandated and they don't want to do a thing but stare at me, then that's what we do, because that's their space, at least a space in which I can allow them not to be decided upon. But yeah, I think it's a really tough conversation.
What I've heard from my community members is that it doesn't work. because there really needs to be buy-in. You know, the person really needs to be committed. Why not spend the money on people who are ready for treatment? I also feel that this perspective puts the focus on the individual without looking at the context, looking at the person holistically. What else is going on in their lives? You know, what is driving the addiction? What is driving mental health crisis? Those things need to be addressed.
Well, and I think in the context of what we're talking about today, the experience of racism, and racism as a structural concept, being a driving force that needs to be examined as a part of that context to get that buy-in. If you're mandating it, isn't that just another piece of the structure, right? Sitting on top of somebody's shoulders and telling them this is what you have to do, as opposed to this is something that you're accessing of your own volition. Yeah. Anybody have any other comments? Okay, we can open it up for questions. We've got our 2 microphones. Oh, good, we've got a line.
That's right, I was ready. Hi, hello. I have a question about implicit bias training, but I want to frame it that I'm a clinical social worker, and I work mostly with adult women with depression and anxiety, and then I work on a macro level in the Office of Health, Equity, and Inclusion at Boston Children's Hospital. So I feel like implicit bias is like super hot right now, like everybody wants to talk about it, and how do we reduce our biases? And so I was doing some benchmarking research recently, and from what I saw, please correct me, this is why I want to ask this question, implicit bias trainings have been shown to reduce implicit biases immediately following the training and have some lasting effects afterwards, but they don't do anything to change explicit biases, and then they don't necessarily do anything to change clinician behavior. And so again, I'm speaking as like somebody who's doing diagnosing, right? Like, and I wonder how much does bias impact the diagnosing, like you were saying, Dr. Cort, and how does it impact just the disparities that we see in health outcomes for Black people in particular. And so I'm curious to hear you all's thoughts on that. Like, should we be focusing our energy and time somewhere else, or perhaps it's the research design? I don't know, so I want to ask.
Sure, thank you for that question, it's very thoughtful. In terms of implicit bias trainings, I think in terms of just interrogating the effectiveness of those trainings, part of what happens, obviously, is that you go to these lovely trainings, they're incredibly stimulating, they challenge your perspectives. However, then you go back into the real world with the same type of exposure that you've had before, right? And I think one of the things to realize is the research highlights that implicit racial bias really starts to really be shown by age 3, age 4. And then really starts to crystallize by 11, 12, right? So that's a lot, right, for us as adults to shave away. The amount of misinformation that we have been indoctrinated and marinated in. So I think the goal is not necessarily to be able to eliminate the automatic and unconscious response that 3-year-olds and 4-year-olds are showing, right? It goes back again to cultural humility, to recognize that you cannot have grown up and lived in this country, right, that for hundreds of years was built with institutional oppression and racism and marginalization, and not be impacted, right? Because you see in research today, 4-year-olds could tell you who the stupid kid is in the classroom, who's the mean kid, who's the smart kid, and that's distinguished by color, right? And you wouldn't call them racist, right? So it's important for us to recognize that what we are working against is incredibly enmeshed, and so what we should be striving for is our recognition and our humility about its existence in all of us, and for us to have humility about the fact that as we sit across somebody who looks different than us, who presents in some different way, that those implicit biases are likely going to be coming up for us. And so with that increased awareness, we can then have the opportunity to take a breath, right, to check ourselves, and then have that regulate our behaviors in a different way. So I haven't come across a different way of really working against implicit bias other than that.
Yeah, I agree. I mean, I think what comes to mind to me, and certainly what comes to mind because I teach in a predominantly white institution, is really this idea that I do want to sort of celebrate the implicit conversation that we're having, this sort of silent force. But I don't think that we're having enough explicit conversations. And I say all the time that I'd rather have a clumsy conversation about race and difference than no conversation at all. And I think what's happening is that there's this silence around even the explicit things, the things that we're conscious about. We're not even interrogating that lens. Like my students walk around thinking that I'm lensless because I'm a black woman. And I'm like, well, I have to interrogate my lens too. I mean, I'm in rooms with people and I have feelings about things, and that sometimes can impact, you know, what I say and what I do in sessions in ways that are not necessarily helpful to my clients, and I have to be aware of that too. And I think that there needs to be a lot more overt talking, even if it falls on the ground and clunks. At least we know that that's what's in your mind, and then we can chop at it. But I think a lot of people are walking around with just silent toxicity that is never said, and there's no opportunity to really dissect it and correct it or think about it because it's never mentioned. So I think the implicit stuff is important, but I think there's conscious stuff that's even more dangerous that's never talked about because everybody's afraid of that kind of gotcha that happens, and that's the stuff I mourn, is that we're in this sort of gotcha mode where nobody wants to say anything anymore because they don't want to be labeled racist.
Yes.
So I find that particularly dangerous. So yeah, great question.
It is. I'd like to say that it's really important to, I think this work must be intentional. It takes commitment, and going to a class, going to a training is not going to do it. It's going to take each one of us to really realize the value and the importance of this for all of us, and to intentionally work on it continually.
I want to second that point about how I think it's a continuous quality improvement issue. This is not a one class thing. To give you some perspective, I was asked by Somerville Police Department to train police officers in implicit bias. And she said, you have an hour and 15 minutes. And so I've done about 10 of these, and we started off and it was a disaster. It's getting better. I want to be there because it's an hour and 15 minutes that they're not going to get otherwise. If I didn't go, they'd get 0. But how do I talk to them in a way that's useful at all? I realize is really hard. And so we spend a lot more time on perspective taking and thinking about explicit things that happen than trying to battle whether the implicit assumption test has the right alpha, Cronbach's alpha or whatever, right? So, but it makes me think that they need continuous training on this stuff in order for it to be at all successful. And then make the analogy is that mental health professionals need continuous training on this. They need that implicit bias class, but they also need space for teams to talk about relationships that they're having with the team and with their patients. And there needs to be updated trainings. And when things are above clinicians' head, there needs to be a specialist. There need to be folks who really understand this stuff that come in and help with that patient-provider interaction. And that should be lifelong stuff. But we're just not there. We're in the hour and 15-minute implicit bias class space right now.
So true.
Hi, good afternoon. I'm a public defender who works primarily with juveniles. My question is about the intersection of trauma and mental health diagnosis. So I was at a training recently on dealing from a trauma-informed lens with adolescents. And there was a discussion about how a lot of times, especially adolescent men of color, are diagnosed with ADHD instead of symptoms of trauma. And much like you talked about, Dr. Cort, of diagnosing somebody with ODD when it is ADHD, I was hoping you could speak to some of the harms of a misdiagnosis of a mental health disorder when in fact it's trauma-related, or how much those coincide. And additionally, if we have time to get into it today, what I can do as an advocate to explain, perhaps not to a provider, but to a court or a decision maker, how a misdiagnosis may continue in manifestation of behavior for a juvenile, and how that should not result in them ending up in the juvenile justice system any further.
Thank you for that question. Interpersonal trauma is a neurobiological risk factor for psychopathology. It's one of the most prominent, primary, common etiological factors that give birth to psychological distress, right? And for most of us, that interpersonal trauma is not inevitable, right? So there are societal factors that have given birth to the traumatic events, which then give birth to the psychological distress. So what I would say in terms of the intersectionality, there absolutely is. There are many ways in which trauma, in terms of your reactivity, impact you and your behavior. It also impacts the way that you're able to even read facial affect. So it impacts your ability to have good interpersonal function. So there are many, many ways in which it shows up. But I think in terms of the issue of misdiagnosis, part of what I think oftentimes gets conflated is the fact that most of us experience extreme traumas. Most of us don't end up with a trauma-related stress disorder, right? Because we have supports, we have people in our lives who help to care for us, that help to buffer against psychopathology. So it's not a one-to-one relationship. I think what you're highlighting is the fact that we continue to struggle with being able to distinguish many of these conditions that have overlapping symptomatology, and they're really complex to treat and to identify. Thank you.
Thank you.
Anybody else?
Hi, I'm Adriana. I'm from the Center for Multicultural Training in Psychology, and I'm a psychology or mental health provider. And my question is kind of multifaceted. So we know that mental health professionals are not exempt from biases, whether they're implicit or explicit, and that we've also been a part of this oppressive system ourselves. So I'm wondering, what recommendations can we give for people who are struggling with symptoms of racial trauma or just the stress from oppression, as far as healing and where they can seek that? And then the other aspect of my question is, as a mental health professional, like, how can we shift the burden or the responsibility of change from the individual who's experiencing these symptoms to the oppressive conditions around them? Because within most therapy protocols, your focus is usually on changing the individual or having themselves make changes within their cognitions and behaviors and all of that, instead of necessarily recognizing and pushing to change the conditions that are causing their symptoms at times.
I'll start, and I want to tee up Valeria a little bit here too. I've been so impressed working with the Transformation Center and learning more about what's happening at Roxbury Presbyterian and their group there, about how the questions that are normally asked about psychopathology and the intake for psychologists and psychiatrists doesn't mesh with the trauma that they've been experiencing. And so you sit through these PHQs and GADs and the individuals wondering when we're going to get to talk about trauma. And so we've been talking about changing the system, one, to get the clinicians out from the hospital walls and out into the community, but then also the questions have to be different. And I've learned that a lot. So I think it relates to this question and the last question in some ways, that thinking about how trauma informs the DSM-5, well, maybe we should leave the DSM-5 for a little bit and really focus on the trauma part.
At the Transformation Center in our recovery learning communities, we first take the assumption that every person who is dealing with mental health condition, addictions, has experienced trauma on some level. And that is part of the reason why we are so committed to affinity group work. I think a key component is having the support of a community, or at least a few others where you can kind of shelter away in a place of safety and really have a chance to speak with people who get it, who really understand. And that has to happen on a regular basis to develop that trust. Then, when that kind of foundation is laid, people are then ready to go out and continue with their lives and continue to do the work, to work with other affinity groups as allies.
Yeah, I mean, I think Valeria's comment about people who get it is key here, right? To your question about how are these conversations about their experiences in the world and how that intersects with a clinical diagnosis. How do we bring that in? How do we have that conversation? And I think, what we found out, certainly in our study, is that it's not that people are not aware that they're having these experiences. They're walking into your office knowing that it plays a role. The issue is, are we providing the space for them to actually say how all these experiences that they're having in the world intersects with they know. So, sort of to Natalie's point, if you walk in and the person that you're going to sit across from has no idea about implicit bias or anything about race, then spin around and leave, because that's not the space in which you can bring the stuff that is affecting your life into the room. Because it's not that we necessarily have to give people that insight. In my experience, people know that they are experiencing racism. People know how that makes them feel. Right? It's whether or not they're in a space where they don't have to define that for anybody, and they can spend some time thinking about how they can cope with it, right? And I think the question of how we sort of change the system is different from that, because I think when I'm in the room, it's really about how I can sort of be in the room and help people think about how their lives can get better and in some way, contribute to that. But I hear you on this. It's a great question.
All right, I want to thank our panelists. We're going to need to move into our wrap-up. Thank you very much for joining us this afternoon.